Good evening. This is Cindy Zolneric with the Texas Nurses Association. Welcome to our broadcast this evening on the APRN Alliance update. Navigating waivers, volunteering, liability, and other issues during the coronavirus pandemic. This evening, we have Kevin Stewart, who is a lobbyist for several nursing organizations, Sam Stinnett, who is the executive director for the Texas Association of Nurse Anesthetists, Aaron Kuzak, who is the public policy director for Texas Nurse Practitioners, Wendy Wilson, who is the lobbyist for the Certified Nurse Midwives, and Jolene Zeich, from the Board of Nursing, who oversees advanced practice. Tonight, we want to provide an overview of the current COVID-19 waivers for APRNs, discuss scope issues and expectations for APRNs that may find work in an RN role, talk a little bit about safe harbor and how we might expect to see that utilized during this pandemic, and then become familiar with some of the disaster liability laws and implications for APRNs. And with that, I will hand off to Wendy.
Thank you, Cindy. As you all may already know, we established the APRN Alliance, a collaboration among all of these groups back in 2015, and it consists of the TNA, Texana, TNP, CTCNM, and Texas CNS. All of us together, our memberships represent over 30,000 APRNs in Texas, and that's growing daily. The APRN Alliance is a partnership of advanced practice registered nurses organizations who seek to advance common interests through a unified voice, which we think is very important not only during this time, but certainly during legislative sessions as well. Here is a lovely photograph of the group of us at, I believe we were at the Texana symposium that they had earlier this year, their member conference, at a panel that we had. As Cindy mentioned earlier, we're going to talk a little bit tonight about the waivers that have been have come down by both the executive order of the governor and the federal government. And here is an overview of what we're going to talk about. There have been a number, and one of the reasons we're having this webinar is to clarify and outline for you what has taken place in the last couple of months. There have been waived written delegation agreements. We'll talk about phone only and telemedicine, controlled substances and chronic pain, a waiver in home health, inactive and retired APRNs that can be called back in with some waiver and exemptions, 6 months grace period and CE leniency for APRNs, CRNA supervision waiver, and then a waiver relating to pain management. So we're going to talk about all of those in the next few slides.
All righty. had to put my microphone on here. So my name is Erin with Texas Nurse Practitioner. So we'll go through some of these one by one. And if questions come up or any clarification is needed, absolutely submit your questions and in the chat box. We'd be happy to get to as many of those at the end of the presentation. One of the very first things that was done when the disaster was declared for COVID-19 was accepting out-of-state licenses in good standing, but also the activation of Rule 172.21, which essentially waives the requirement for written delegation agreements for APRNs as well as physician assistants. And that includes prescriptive authority agreements, facility-based protocols, And while the written delegation agreement is waived, it's important to note that this disaster rule still requires that APRNs and PAs have a delegating physician. And specifically, it has to be a Texas licensed physician who was already practicing in the state prior to the emergency. So delegation hasn't been waived, but the written requirement and contract has been waived. And this new form of delegation can be informal. There's been subsequent announcements from the governor that have clarified that this can be a verbal arrangement or a form of verbal delegation. But it's important to note that a delegating physician is still needed of some kind, and that also controlled substances, at least for the time being, are not included under this waived delegation under the emergency delegation rules. You can prescribe drugs and devices, dangerous drugs, antibiotics, but at this time, there's no waiver for controlled substances under this emergency delegation rule. And next slide. So the other very, very big waiver that was announced at the beginning of this public health emergency was phone-only consultations, allowing providers to establish a valid provider-patient relationship via phone only. There were a lot of changes to telemedicine law from previous sessions that do allow phone in general for telemedicine, but in combination with some other store and forward technology. But for the duration of the disaster, providers are permitted to use phone only, to meet with their patients, to treat them, to prescribe for them. And in addition to this state level waiver, there's been a number of federal waivers that are of note. You can prescribe controlled substances without an in-person evaluation, and that has something to do with the Federal Controlled Substance Act. So that is a very big change as well. But this has really opened up the door for a lot of providers, including APRNs, to start using telemedicine and telehealth for their patients. And it's been something that's been very helpful, in particular during the shelter in place and stay at home orders that we've been seeing across the state. So this is something, and if we just click one more, another map should come up. This is a map for nurse practitioners in particular, but I think it's helpful just to get a picture. In a lot of these states, APRNs are regulated together, so if it applies to nurse practitioners, it applies to APRNs across the board. But this first map is showing the number of states that have allowed out-of-state and in-state retired and inactive RNs and APRNs to practice. And you can see the vast majority of states have done that, including Texas. In the second map to the right, you can also see the states that have waived or made changes to delegation requirements for APRNs. 22 states and the District of Columbia already have full practice, so those states are in light gray, but the states that are in light blue have made at least some changes to delegation. So in the example of Texas, we've waived written delegation, and a handful of other states have done that as well. But the states in dark blue have waived delegation requirements across the board, including our neighbor Louisiana. So those states are currently not requiring a delegation agreement. And because of some of the telemedicine provisions in place in the state, right now we are having some Texas APRNs who are providing telemedicine to Louisiana patients without delegation requirements. And that would be okay because of these out-of-state licensure waivers or accepting licenses in good standing, as well as some of the changes that have taken place for telemedicine. But this map to the right is changing all the time, and I expect that it could even continue to change in the coming weeks and months. Something that is very positive and beneficial going forward is home health. This has been an ongoing legislative agenda item for national associations as well as state associations, but There's nothing in state law that prevents nurse practitioners or APRNs from being able to order home health or order durable medical equipment and supplies that is explicitly written in as part of the scope of practice of an APRN in Texas. However, there's long-standing CMS rules that prevent nurse practitioners and APRNs from being able to do this for Medicare as well as for Medicaid. So the CARES Act, which was the huge coronavirus aid relief and economic security act bill that included both stimulus money and relief to the healthcare system and some other provisions for the duration of the public health emergency, it also included a provision on home health, and this provision is permanent. So in 6 months, CMS has 6 months to implement this. APRNs will be able to order home health and prescribe DME. And there's emergency rules in place for Medicare specifically. So if you have Medicare patients or patients who are Medicare beneficiaries, you're immediately able to start doing this. You don't have to wait for the full implementation of this law in 6 months. There is a little bit of a caveat there with Texas Medicaid. So far, Texas Medicaid has not issued emergency rules for home health. So there's no changes to the Title 19 form right now that currently requires a physician signature, but we're hopeful that this will be changed in 6 months. And in the meantime, for Medicare, this change is in effect under emergency rules. So that's a really big help for a lot of APRNs who are caring for seniors and the elderly, especially from their homes.
Hey guys, it's Kevin Stewart. I'm talking about some general licensure issues. I think the biggest thing that happened as far as licensure goes, and this applies to all our APRNs and then RNs as well, is that the Board of Nursing and with the governor's office have put together what's being called a 6-month licensure grace period. And so basically, the period between March 23rd and September 30th is going to be a grace period where you can let your license lapse and you will be able to continue practicing. And when you return, you're not going to have the late fees that are typically incurred if you let your licensure lapse. You're not going to have to submit evidence of CE. And actually, this also applies to prescriptive authority, so very useful for nurses. The other thing, I mentioned that you're not going to have to show evidence of CE, but the board still wants you to do your CE. And that's where this other provision comes in. Basically, the idea is if you have a good faith excuse, a reason why you just couldn't do your CE, the Board of Nursing has basically agreed to be lenient. And that's going to be done on a case-by-case basis. If you do expect that you're going to have an issue meeting the CE requirements, make sure to keep good records and sort of reach out to the board early so you can ensure that you're going to get exempted. But that's something that should be helpful. We really didn't want nurses worried about CE and renewals at this time. And then for retired and inactive APRNs, if you're an APRN returning to practice, as long as you've been in practice within the last 4 years, you won't have to pay the reactivation fee, complete the continuing education, or the clinical hours. The other thing, it's not finished yet, but the board has requested a waiver of the certification requirements for APRNs who have just graduated. Obviously, you're not going to be able to take those sort of certifying exams anytime soon. The board wants you to be able to practice. We want you to be able to practice. So this would basically allow APRNs to practice who just graduated and can't otherwise get their certification.
Hi, it's Sam Stinnett with Texana. Prior to COVID-19, the Center for Medicare and Medicaid Services, CMS, required CRNAs to be supervised in order to seek reimbursement for services provided to Medicare and Medicaid beneficiaries. This is sometimes called opt-out because governors have the authority to opt out of the requirement in their state, and the federal government has waived this requirement during the disaster. And then regarding pain management, uncontrolled substance refills, refills of Valid RX are allowed through telemedicine for treatment of chronic pain with an established chronic pain patient through May 8th, 2020. The standard of care still must be met, and this does not expand a provider's authority to prescribe controlled substances that they otherwise would not be able to prescribe.
Hi, this is Jolene Zeich, and I'm staff of the Texas Board of Nursing, and I've been asked to just talk a little bit about APRNs working in the RN role. So Cindy, if you would advance the slides, please. Thank you. I want to lay just a little bit of foundation for what I'm going to say, and it's important to remember that in Texas, APRNs have 2 licenses minimum. Texas Advanced Practice Licensure is linked to the RN license. As you know, as we think our way through education, we start with RN education, and our APRN education builds on that RN education. So the licensure process is very similar. We have an RN license as a foundation, and then an APRN license here in Texas that is linked to that RN license. If you don't have an RN license, you can't get an APRN license. And there's 2 ways that we look at that. If you're living in Texas and you're a Texas, or you're in a state that is not part of the Nurse Licensure Compact, you have a Texas RN license. However, for our party states, and we are now surrounded by states that are party to the Nurse Licensure Compact, as long as they have a multi-state privilege on their home state RN license, we accept that as meeting the RN requirement. So our colleagues in New Mexico and Arkansas have been able to do this for years. More recently, Oklahoma and Louisiana have joined the compact. And so we're able to use that compact privilege for those nurses who live in those states. And they do have to meet residency requirements to get that compact privilege. But we link their Texas APRN license to their home state RN license. Next slide, please. So now that I've clarified that we have 2 licenses, I need to point out that sometimes people get really confused about this concept, and especially employers. I have heard for years, I've been with the board almost 21 years, and over that time period, I have had a lot of phone calls from APRNs who say, I've got my APRN license, I want to still work as an RN, and my employer says I can't because I have an APRN license. Well, that's simply not true. You still have an RN license, and you are still entitled to the full scope of RN practice for which you are competent. We've clarified that in the rule, and I provided you with that rule. And it's kind of funny because for all these years, I've heard that APRNs could not practice in the RN role. And now I'm hearing from employers who are demanding that APRNs practice in the RN role, as well as from APRNs who want to assist and practice in the RN role. So it's kind of an interesting change. Next slide, please. So what is it that we need to know when we're moving from an APRN role to an RN role? I want to point out that the standards of nursing practice apply to all nurses, and those are found in Board Rule 217.11. And I want to specifically note 217.11(1)D that says as nurses, regardless of our level of licensure, we only accept those assignments that take into consideration not only patient safety, but that are also commensurate with our education, our experience, our knowledge, and our physical and emotional abilities. So for example, I did critical care rotations when I was in nursing school, but I never did critical care nursing once I left nursing school. So if I'm going to go back and step into an RN role, that's not the place for me. If you've never practiced in the ICU, that's probably not the place for you to jump in right now, unless you're going to get a really good orientation. The board also has position statement 15.15 that talks about the board's jurisdiction over a nurse practice in any role and use of nursing titles. This position statement clarifies that nurses can accept nursing assignments for any role for which they hold a current license. So once again, reinforcing that even though you have an advanced practice license, you also have an RN license. And so it is absolutely acceptable for you to step into that RN role if you're asked to do so or if you wish to do so. Now, it's real important to point out current competence. For example, if you're a neonatal nurse practitioner and you've been working as a neonatal nurse practitioner for the last 20 years, your competence to step into the RN role is probably going to be much higher for pediatrics and neonatal care than it would for, say, geriatrics. So it's really important to think about what your current knowledge and skills are. It also points out that when you step into that role, you are held to the level of your education. So even though you're working in the RN role, you still have your knowledge and your competencies as an advanced practice nurse. You don't lose that. You have to make sure that you still use that knowledge without exceeding your scope of practice. So for example, when you're practicing in the RN role, you're not going to be engaging in acts of medical diagnosis. You're not going to be writing prescriptions or ordering something like durable medical equipment because you're practicing in the RN role. However, you still have your level of education. So for example, APRNs have extensive education in assessment, and they have a much higher level of assessment skill than many RNs do because of their advanced education. We don't lose that. And so for an example, let's say we have someone who's educated in pediatrics and they're doing an assessment on a child and the child has a hip click that could potentially lead to a hip dysplasia. While they're working in the RN role, they can't make a diagnosis and they can't make the appropriate medical referrals, but they can certainly alert the appropriate medical provider at that time who can then take appropriate action. So it's real important that when we work in the RN role, we know that we can do that. We certainly want to support our colleagues in any way that we need to, but it's real important to remember what role we're working in and to use our education and our skills to the best that we can. And I believe Cindy is next.
Had to unmute. Okay, so when we talk about APRNs working in RN roles, and we take that into the current context of a crisis, of a COVID pandemic that we're currently experiencing, we're seeing some models emerge in terms of how APRNs may be incorporated to meet surge demands if and when they occur during the pandemic. This is from the Society of Critical Care Medicine, and it kind of demonstrates, and we're seeing some organizations adopt more of a team approach to care, where a team of providers care for a group of patients, thereby maximizing the skills that each bring to the bedside. So here is an example that utilizes CRNAs in a critical care situation, because they are expert at airway management. And we know with COVID that a number of these patients, the most serious cases, will need ventilation. And that is very, very much aligned with the CRNA level of expertise. So it's one example of what we're seeing in terms of how APRNs may be incorporated into different kinds of models to deliver care. Now, I'm going to talk a little bit about safe harbor, nursing peer review. Sometimes APRNs, this isn't front and foremost in their mindset, but this is a protection that they also enjoy because they are nurses, and safe harbor protections apply to all nurses. So The Rule 21711 requires both nurses who are making an assignment and nurses who are accepting an assignment to consider patient and safety. And that really aligns with what Jolene had just spoke about in terms of whenever we're considering assignments, we need to be considering what is safe, what the nurse's individual competence and ability to care will provide in terms of safety for that assignment. Safe harbor most often is applying when there is a different perspective among what is a safe assignment, between the person who's making the assignment believes that it's a safe assignment, and the nurse who's accepting the assignment may say, whoa, no, I don't feel safe in this situation. So the safe harbor is most commonly used in that situation, probably most often when it has to do with the numbers of patients or the acuity of patients that a nurse is assigned to. Safe harbor enables the nurse to accept the assignment and have certain protections. The right to a peer review committee who will look at the situation and consider the nurse's duty to the patient in that situation under question. And it would have accepting that assignment have violated the nurse's duty to the patient. So if the nurse does not feel they can safely care for that patient assignment, whether it's due to the number of patients, the acuity of the patients, or some other situation, that nurse should not accept that assignment. And that peer review committee takes that under consideration. I want to backtrack a minute and say should not accept. It's rare that a nurse should refuse the assignment. Usually the nurse should accept it, but it does need to be reviewed to provide further guidance to the organization in terms of what is a safe assignment. I'm also going to interrupt myself here, and I apologize for that interruption and flow, but I forgot to mention in the very beginning, if you have questions, please enter them in the question box that should be appearing to the right of your screen, and we will take up questions at the end of the presentation. Thank you. Safe harbor provides protections to the nurse for retaliation from the employer. So this is seen as a patient advocacy activity where the nurse is advocating for patient safety. And therefore there is protection in that action that the employer cannot retaliate against that nurse for requesting safe harbor. Thirdly, if conduct occurs during that safe harbor, say the nurse is requesting safe harbor because she believes that the patient assignment is too heavy, there are too many patients to take care of, and believes that she can't safely manage that group of patients, and accepts that assignment, and then makes a med error. Maybe meds are passed late because they couldn't be passed within the usual time frame just because the number of patients, the number of meds. That would not be, the Board of Nursing would not discipline the nurse based on that error because he protected under safe harbor. If you are not muted, please mute your line. Thank you. So the nurse should not engage in the requested conduct. That is, the nurse should refuse the request if and when the nurse lacks the basic knowledge, skills, and abilities necessary to render care. I think the example Jolene gave earlier is a great example. So if I'm a neonatal pediatric nurse practitioner, and I am asked to care for patients in a general psych unit in an RN role, I may not have the basic knowledge to provide safe care in that environment because that's not where my current competencies are. Or if I'm a med-surg nurse and I'm asked to float to the ICU and take a regular ICU assignment, that I may be more of a risk to those patients than someone who can contribute to their care. So I should not take that assignment. There may be adjustments in the assignment, however, that may make it a safe assignment. So if I'm a med-surg nurse and I'm being asked to float to an ICU and provide a specific level of care, say be responsible for some basic hygiene needs of patients and managing some basic care that I would normally manage on a med-surg unit, and have access and also have an ICU nurse assigned to that patient, that might change the safety of that assignment. So it's not based on what unit you're assigned to. It's really based on the care that you'll be providing to that patient, and do you have the competencies to provide that care. The other situation in which a nurse should not engage in requested conduct is if the conduct would constitute unprofessional conduct or criminal conduct. An example I can provide is one that I actually experienced. However, it was in a different role and in a different state that did not have safe harbor. And I was in a leadership position, and I was told by the CNO there were some records, competency records for nurses that were unable to be located. And we were expecting a return visit from the Joint Commission and the CMS. And I was told to recreate those records so that they would be available. I believed that that was unprofessional conduct and would have needed to refuse that request. And had I been in a state that had safe harbor, I could have evoked safe harbor and then refused the request, and I would have been protected from any kind of retaliation from that role. So consider this broadly, not as most commonly is with patient care assignments, but it can apply to other kinds of situations. Safe harbor does not protect bad faith requests. So you have to really believe that the safety is being compromised. You also, if you are requesting safe harbor for something that has already been reviewed by a peer review committee, and the peer review committee believed it was a safe request, then to re-request review of the same situation would not be considered good faith. Safe harbor does not cover actions that are before you revoke it. So it's very important to invoke the safe harbor at the time the assignment is made, and I'm going to talk about that. And then reportable conduct that you engaged in that's not related to the request. So if I invoked a request and then I did something, I engaged in unprofessional conduct that wasn't related to the patient assignment, that would not be covered by safe harbor. It also does not protect you against civil action from patients. You can still have a civil lawsuit for an error that may have occurred. Some key points, and I will identify this as a really quick review. There are more information and resources both on the Board of Nursing's website as well as on TNA's website, and we both offer continuing nursing education opportunities on this particular topic. So key points, safe harbor must be invoked prior to engaging in the conduct or the assignment, and when the conduct is requested or the assignment is made. So you may wonder, what is an assignment? It's when the request is made. It can also be when changes occur. So I may begin a shift with a certain assignment. Maybe I have 6 patients, and then one patient goes downhill really fast and requires me to be at their side 1-to-1 until they can get transferred to the ICU. Well, that changes my assignment. Now I'm not able to really oversee the care of the other 5 patients I was assigned to. In that case, I could say safe harbor. My assignment is no longer allows me to safely care for this cadre of patients. And on that request, what's expected to happen is a supervisor works with a nurse to resolve that situation. And in that situation, it might be, okay, let's divvy up those 5 patients to other nurses on this unit who can cover until we get the patient who's critical right now into a safer environment. Safe harbor also needs to be requested when the nurse refuses to engage. And I mentioned there are very narrow circumstances when the nurse should refuse to engage, because most of the time, the patient is going to be better off with that nurse than without that nurse. So the procedure is the nurse must notify the supervisor, and request must be in writing. Now the caveat to that is this last session, a provision was allowed that request may be made orally. And the intent of that is there are situations such as when you're in the middle of a procedure where you cannot leave that patient's bedside to write the request. That may occur during this COVID crisis when you are fully gowned up and gloved and masked to with PPE to protect yourself and the patient, and to ungown and take off all that equipment would leave the patient in an unsafe situation for you to exit the room and put something in writing and give it to the supervisor. In that case, you may make the request orally to the supervisor, who will document it for your signature later. There's more information on how to actually make the written request on both the board's website as well as TNA's. And with that, I will hand off to Kevin.
Thank you, Cindy. I'm just going to go through really quickly APRN liability during disasters. All right, so the first big one, we talked about the CARES Act earlier. Another provision that was in that is a liability protection. One of the issues with that liability protection is that it only applies to volunteers. So, you know, if you're just at your job, it's not really gonna help you. Also, it has to be within your scope. So even if you're volunteering, if you do something that's outside of your scope, you're not going to be protected from liability. And the way the CARES Act is worded too, you only have protection if it relates to the diagnosis, prevention, or treatment of COVID-19 or care for a patient with actual or suspected case of COVID-19. So it's not going to extend to activities that are outside of disaster response. It also doesn't protect against like gross negligence, criminal misconduct, areas where you're really at fault. The next one is the PrEP Act, and sorry about that. The PrEP Act, this was passed in 2005. It's a broad, and it was recently extended to COVID response. It's a broad immunity to professionals, so it includes, it's outside of volunteers, it's any healthcare professional. It does only apply to quote unquote countermeasures. And so the way it's written out is, you know, it's stuff like antiviral medications, vaccines, diagnostics, and/or devices. And so in the COVID context, it really applies to stuff like testing and respiratory therapy. And that again is sort of limited to treat, diagnose, prevent, cure, or mitigate COVID-19. There are also some things in state law. One of the provisions we have is very similar to the CARES Act. And I will say the way the federal laws and the state laws interact is that the federal laws preempt the state laws only insofar as the state laws are less protective than the federal laws. So if you'd be protected under the federal laws, you're protected. And then if you'd be protected under the state law, but not the federal law, you're still protected by that state law. It doesn't preempt it completely. It only preempts it when the state law is less protective. Again, the state law is very similar to the CARES Act. It only applies to volunteers. It only applies when you're acting within your scope. There is another protection in state law. Again, it's a volunteer one, but it's for people who sign up on the sort of texas.gov registration website. So really, you know, the PrEP Act, you know, if you're not a volunteer, the PrEP Act is going to be the most protective one for you. Oh, I'm sorry. I did want to hit on this governor request too. THA and TMA and some other groups have been working with the governor's office to expand some of those protections to any providers who are in hospitals. We haven't heard anything yet, but as soon as we do, we'll get information out to members.
Okay, now we're ready to take your questions. Again, reminder, put those in the chat box. And Serena Bumpus, TNA's Director of Practice, is going to read off the questions, and the presenters that are most able to answer will jump in. Serena?
Okay, so thank you all for being here with us tonight. Our first question says, is there a form or document I need to complete to be approved for the emergency state licensure? I have an inactive APRN Texas license and meet the criteria of having clinical practice in the last 4 years.
This is Jolene, and I'll go ahead and take that one. There is a form that's available on our website. On our website, we do have a special COVID-19 information page, and there is information about reactivation. It's the normal reactivation form, but you're going to write waiver on it. Complete the form, send that along with a copy of your current certification into the board office to Mr. Mark Mayak, who is our Director of Operations, and his email address is on our website as well as our fax number if you need to fax it.
Thank you. Next question says, my delegating physician recently retired. Thus, I'm not able to prescribe. However, in an effort to aid with COVID-19, I'm set up with telehealth. How would I go about reaching out to Louisiana to provide care since they've waived the delegating physician requirements?
This is Erin with Texas Nurse Practitioners. I'm not sure if there's a central entity that is accepting volunteers right now or recruiting volunteers in Louisiana, but I would look at their volunteer disaster registry there or contact the Board of Nursing in Louisiana to see what the need might be. There are definitely nurse practitioners who are either physically locating to some of those states or who are providing telehealth or telemedicine to patients who are located in those states. But there's no sort of central body that I'm aware of that's coordinating that, but it's something that we can look into and we can share if we're able to find out information.
And the next question also pertains to Louisiana, and they're asking if they are required to inform the Texas Board of Nursing if they're able to aid and assist in Louisiana.
This is Jolene with the Board of Nursing, and there's nothing that you need to do with our board to assist and aid in another state.
Okay. Next question asks, is there a limitation does the APRN have any limitations to be a telemedicine screener for COVID?
That's a good question, and one I don't know the answer to, but definitely something we could look into. Off the top of my head, you know, there are very few sort of restrictions on telemedicine right now. I don't know how that would sort of interact with screening, but I would think that there would be no restrictions. But if you want to follow up with us after, we can dig into that for you.
And the last question, I don't see any more questions coming in just yet, but the next question is in relationship to the tiered staffing models that some of our facilities are putting in place in preparation for surge staffing. And it says, how do you reconcile the team nursing model with having a non-ICU nurse / APRN and be assigned to an ICU team that has patients on ventilators and drips?
This is Cindy. I think one best practice that I've seen, actually, Serena, you sent to me earlier today, so feel free to comment. Baylor Scott and White, on the advisory board, there was an article that was published if not today or yesterday, very recently, where they shared their model, and they have very, very specific roles defined for the different individuals on the team that are within their scope of practice and where their competencies might be. We're to utilize non-ICU staff in an ICU environment that have direct access and quote unquote supervision, not legal definition of supervision, but direct access to critical care staff in those environments. So that's one model that I'm aware of. I think there are others that are developing. I know there's actually a model that that I had been exposed to some time ago when I was in a hospital environment where we actually involved respiratory therapists in a greater role in ICU, again, more of a team model during an influenza epidemic. So what's really important is that the roles are clearly defined and everybody knows what everybody's competency is and what they are contributing to the care of the patient. And I also know our clinical education for nurses has kind of moved away from the team approach. So for some nurses who have been nurses for a while are more familiar with that team model than nurses that may have graduated more recently. Serena, do you have comments from your understanding of the team model?
Most of those, the nurses in those teams have very delineated roles. So, for example, the non-ICU nurse working with the ICU team and with patients on ventilators, that nurse would strictly be doing focused assessments. They might just be doing Foley care, skin assessments, that sort of thing. Very basic nursing care that wouldn't require you to manage the complex things like the drips and the vents and that sort of thing. They would leave that to the nurse who has the specific ICU skill set. Let's see, next question. I work in a transplant clinic, strictly outpatient. My employer will require us to work on the inpatient floor for our transplant patients pre and post-operatively. I'm a certified FNP. Will this be outside of my scope of practice?
That's a good question, and it depends on the services that you're being asked to provide. There are certainly some services that are well within the FNP scope, even though you're in an inpatient setting. It's not the setting specifically that determines scope of practice. It's the patient care activities and the patient care needs and the patient's condition at the time that the services are provided. So there may be things that as a family nurse practitioner you can assist with in the inpatient setting, both pre and post transplant. There may be others that are beyond your scope, and that's where collaboration with your acute care NP colleagues or your physicians is going to come into play. And it's important that you recognize where you're reaching the edges of your scope of practice, and it's time to consult and refer. But there are things that you could do, and I think stay within your scope of practice.
And there are a couple of comments on here related to that. Someone commented they've heard that pediatric NPs are being asked in ICU to provide acute care nurse practitioner care up to 30 years of age or more in New York. And that's just alarming to them because it was outside of their scope. And let's see, next question is, given the ongoing outbreak, we're doing many routine follow-up visits for patients via telehealth and are encouraging them to treat their pain episodes at home rather than seek care in the ED. Under the new telemedicine allowances in regards to prescribing controlled substances for chronic pain, is there an accepted definition of chronic pain?
Yeah, the
There
board,
actually
Oh, sorry, go
Go
ahead.
ahead, Kevin. There actually is a definition in the board's rule for the purpose of treating chronic pain with controlled substances, and it's actually in the telemedicine rule, 217.24. And for the purpose of that rule, chronic pain means a state in which pain persists beyond the usual course of an acute disease or healing of an injury. Chronic pain may be associated with a chronic pathological process that causes continuous or intermittent pain over months or years. So that's the definition that the board has used in its rule.
Okay. And the next question is, I just want to clarify that APRNs are able to write for home health orders and DME effective immediately.
So this is Erin, and anyone can feel free to chime in on this. It is only effective immediately for Medicare under emergency rules that the Centers for Medicare and Medicaid Services put forward. However, it is not effective immediately under emergency rules for Medicaid. Medicaid has not yet made any waivers or changes to the program to allow NPs to assign the Title 19 form for the Texas Medicaid program. In 6 months, the emergency rules will be replaced with permanent rules, but that's 6 months into the future. But for the time being, Medicare is okay, Medicaid is not okay.
And one thing I'll add on the state side is actually before the emergency rules at the federal level, Governor Abbott requested basically the same thing on the state level. So there definitely is interest on the state level. It's just things are kind of starting to grind to a halt in some of the government agencies. So I think it's something that we should expect to happen soon on the state level for Medicaid. It just hasn't happened yet.
Okay, and then another clarifying question along those lines is, so are you saying it for Texas Medicaid, it will be okay in 6 months due to the CARES legislation?
That's another one. And Kevin, feel free to chime in on this as well. In 6 months, it'll be definitively for Medicare. It'll move forward. State Medicaid programs have a new rule that will authorize them to make permanent changes to the Medicaid program, but the states have to proactively make changes to their plans and to their state rules and regulations to allow APRNs to order and sign for home health. We have no reason to believe that Texas Medicaid would not do that, but they need to proactively make state plan amendments and changes to their state rules and regs in 6 months to allow this to move forward.
Yeah, I think that's exactly right. I mean, even if the state did an emergency waiver, kind of how like I was saying, the governor requested, there are rules in state Medicaid that require a physician signature. And then, you know, if you've ever seen the Title 19 form that was referenced earlier, that also requires a physician signature. And historically, that has really just been based on the requirement at the federal level. So the federal level made the requirements, and then the state, you know, when they were adopting rules and putting forms together, they just put that requirement in there. So now that the federal requirement is gone, you know, we just kind of need, it's more of like a cleanup, but for the time being, no, you would still need a physician signature for Medicaid.
Okay, and so have one more question that I think will provide a good final thought here. What is the future outlook for supervisory delegations in Texas? Are we moving closer towards allowing advanced providers to practice without a collaborative physician?
I'll say that I think this disaster has exposed some real issues with the way delegation works in this state. You know, Erin kind of mentioned this earlier, but the fact that you need a physician licensed in Texas delegating to you, it just doesn't work. I mean, you know, if you're a nurse practitioner out in Montana or Minnesota or something like that, and you're wanting to telemedicine in, there's just absolutely no way that you're going to get a delegating Texas physician, you know, even if it's just a verbal requirement. So I think in a way that, you know, obviously this pandemic is a horrible thing, but it really has exposed some flaws in the delegation model and just the dual regulatory model. You know, there's everything that happens with the APRN has to be cleared through both our board and then a completely separate medical board. And you know, what they're going to do is sometimes a wild card. And so these are all things that I think, you know, the groups are going to take to the Capitol and discuss with legislators and kind of discuss where things went wrong. And hopefully everybody will come out of this with a better understanding of the things we've been saying this whole time. I don't know if you have anything to add, Erin or Cindy.
I would just echo what Kevin said. I think this has exposed a lot of the complications with the duplicative regulatory framework that we have, and also how this impacts things like telemedicine and the ability for nurses and APRNs to practice across state lines. So I think there will be a number of waivers and changes that might be here to stay, or that are looked at closely in the legislative session. I also think that this crisis is not over. Right now, I think we're at a particular moment in the pandemic, but I think that we could be in a public health emergency for the next several months, and that emergency will look different at different phases in the process. And I think APRNs will be very, very critical at the point where we reopen up healthcare services that have been delayed, postponed, or canceled during this time. And so I think while waivers have kind of been slowed down right now temporarily, I think there could be potential future waivers to address other parts of the pandemic when different needs arise. So it's something that I think all of our organizations are working on together. We're working on it as the APRN Alliance, and I think that there's some positive things that can happen going forward.
This is Cindy. I was encouraged by Senator Cornyn during our webinar with him yesterday. Made a comment that the waivers of regulations trying to remove barriers for care, that we will learn from this, and we may learn that some of these barriers are unnecessary and the waivers should, you know, be continued more permanently. So I thought that was encouraging. You know, he didn't say specifically what that might mean, but I think that is kind of on all of our minds in terms of how will healthcare delivery overall be forever changed by what we've learned through this crisis, because I think there have been many lessons along the way, and one of them being the barriers to access because of the unnecessary restrictions in APRN practice. Do we have time for one more question, if there is one more?
We do. So I think these are two quick questions here. One is there's still some, if individuals still have questions around APR telemedicine practice, who can they contact?
I think the Board of Nursing has some great information on their website. You know, also, I'm not sure which state association you're here for, but I know the state associations have done a lot to put information on their websites. So always feel free to reach out, and if we can't answer your question, we can get it to someone like Jolene who can provide an answer.
And actually, that's it. No more questions.
Perfect
Okay,
timing.
well, thank you everyone for joining us this evening. This webinar was recorded and will be posted. The link will be shared with the APRN Alliance group, so all of us can post it on our website for you to access, or if someone missed the presentation that you know who's interested, they will be able to access it from the website. So with that, I'm going to end the broadcast. Again, thank you all for joining us. We appreciate your participation, and be well and be safe during this crisis. Thank you.